So, good afternoon, everybody. And we are going to talk about a very important perspective with regards to various guidelines. So, this is a new initiative that we have started. So, we want to, over the next 2 years or so, cover all the possible guidelines which are there on different aspects of pediatric as well as some which are overlapping with pediatric. Good afternoon, everybody. And we are going to talk about a very important so there will be so whatever overlap is in terms of adult and pediatric guidelines. So this is going to be an interesting session. This will be complementary over our other sessions like the journal club, the grand round, and the case-based discussion and the PG lecture series. So today we're going to focus on three very important guidelines which are related to different topics, particularly with regards to the growth, with regards to the gender discordance, as well as type 2 diabetes in children. Now, we know that there is a lot of research which is going on continuously in the field of pediatric endocrinology across the globe, and a huge number of publications which are there, which happens. But unfortunately, most of those publications do not result in changes in terms of our clinical practice. The reason for that is that we cannot go and look at each and every paper individually. So guidelines are in a way a bridge so that we can look at the current evidence available and which will tell you whether you need to change your practice or not. And this is what the theme would be. So why do we review guidelines? Is that because this provides us information which is evidence-based. Now, most guidelines are by the leading experts which are there from the group. So today we're going to talk about guidelines which are coming from the International Society of Pediatric Adolescent and Diabetes, the multiple pediatric endocrine societies which postulate the SGA guidelines, as well as the endocrine society. So they are usually evidence-based and they provide us some perspective as to what is relevant from a clinical perspective, and a huge amount of data is filtered from that regards. We know about what's happening in that particular field, and often it is very difficult to understand, interpret. So this is like something which is made easy for us to not go towards all that literature review, and we go from that perspective. So what basically we are going to do is to basically try to cover the various aspects which are relevant in terms of guidelines and that perspective. All of you can go and have a look at our website, learning.growsociety.in, which provides a lot of information about various aspects of pediatric endocrinology. We've got various courses available which provide insights and other tools for pediatric endocrinology. There are a lot of other activities like journal club, like grand rounds, as well as the lecture series which is there. There are publications as well as the mobile application which can be used from that regards. So today I'll be focusing about three specific topics. The first topic which will be taken by me would be on type 2 diabetes guidelines. Then we have Dr. Dhwani who will be talking about the SGA guidelines by the International Pediatric Endocrine Society Consortium. And then Dr. Dhwani will talk about the gender discordance guidelines via the Endocrine Society and how do we assess from an endocrine perspective largely from that regards. So as I said, we will try to focus about all this. What is the evidence, what is the state of art, and how we can implement it. So what we have done is that we have used cases to pose specific clinical query where there is a lacunae in terms of current practice and see what these guidelines change, whether we need to change our management, our assessment, and other aspects on that regards. So when we look at a guideline, we have to particularly look at how much literature they have really reviewed. So that becomes important. Whether they have used a standardized protocol, which is the grading protocol for evidence, which I'll touch base about a bit in the next slide. What weightage is given to individual aspects and whether there is any particular bias or not. So what guidelines we are talking today are based upon the well-known international bodies which have published so many guidelines. So many of them do not have all these issues. But whenever you are assessing, look at how much literature was reviewed, who were the people involved, whether they were showing any bias in that regards or not. And that's why this grading of evidence becomes extremely important. Now, remember that guidelines are not the all end all as far as clinical practice is concerned. Now, generally, guidelines tend to dictate that this should be done. Now, you should remember that this should be done in an ideal situation. Now, every child is different. Every scenario is different. There are socio-economic, racial, ethnic, so many issues. So we cannot just follow everything which is there on the guideline. We have to adapt them. Second, they do not talk about individualized care. So we have to individualize the management, as I said. More often they are community based, and often feasibility issues are there. You have some complicated investigation or some very expensive treatment which is available, which you cannot utilize in your patients. So you don't have to really think that, okay, we are doing something wrong. So you have to basically go through the guideline and try to see what you can do within your resources. And that's what we'll try to do. The first guideline I'll focus about is the just recent guidelines published last year about type 2 diabetes in children and adolescents. And we all know that type 2 diabetes is a major problem. Globally, in certain areas, we have now more adolescents who present with diabetes who have type 2 versus type 1 diabetes. And we are also seeing an upsurge in that regard. So management of type 2 diabetes has been an area of a lot of active research. A lot of work are coming up, a lot of trials which have now gone through multiple phases have come up. And they've clearly shown that diabetes in children and adolescents is much more aggressive as compared to adults. The loss of beta cells is also much more rapid, and the need for multiple therapies is much more. So we need to think about hit early, hit hard in terms of management of diabetes. And this perspectives have changed over the last decade. So earlier people were saying, okay, you go a bit gradual, you treat to failure. When your sugars are not controlled, you start a medicine. When it's not getting controlled, you start the next step. Now we know that the first year of treatment is very important because of the legacy effect. So a good glycemic control in the initial years has got a lot of benefits which happen subsequently. So now we are shifting from a treat to failure to treat to target approach. So your HbA1c should be below this, your sugar should be below this, and we don't want you to fail. If you are good, if it's too tight, you get down or you step down in terms of treatment, and that's what the major change is. So we'll see what has been the upgrades with regards to the 2022 guidelines from that perspective. So we'll start off with the first scenario. A 12-year-old boy with obesity who is having a BMI of plus 2.2 SDS, so significant obesity, has got acanthosis and a family history of diabetes. This is a run-of-mill presentation that we see day in and out in our endocrine clinic. Now the question is whether this child requires assessment for the glycemic variability, whether this child needs evaluation for the glycemic status. If yes, which test is the best, and how do we interpret those tests? So this is a big question that we have to answer. Now, if we go via the ISPAT guideline, they clearly show that we should do anybody after 10 years of age or onset of puberty. And this is something which we have also seen. That type 2 diabetes and even pre-diabetes is exceedingly rare before 10 years of age or before puberty. So any obese pubertal boy or girl, we have to evaluate. This is one thing which they have mentioned. And they are talking about even the overweight category. So although we haven't seen many patients in the overweight category who do develop type 2 diabetes, but they also talk about overweight. Now, Dr. Dhwani, what do you think? If we compare somebody who has pre-diabetes versus diabetes, who would have more BMI? Pre-diabetes or diabetes? At presentation. Diabetes. Vibha? It is an interesting loaded question. Why I'm saying at presentation. Often patients with diabetes may have lost weight. So we have seen patients, that's why when you talk about our cutoffs of BMI standard deviation score, we talk about overweight cutoff for type 2 diabetes rather than having a obese cutoff. So because of the loss of weight, it may happen. But so what they're saying, anybody who is overweight should be assessed. So this is an important point to think of. Now, what test they say is fasting glucose, 2-hour value, and HbA1c, the standard guidelines which are there. And if you compare these three tests, and this is based upon our own understanding, is when you talk about fasting hyperglycemia, you mean this child, even the basal state, has high sugars. When you have talking about HbA1c, it is the overall mean. So sometimes going down, sometimes going up. And when you talk about after glucose load, this is only when you are eating out. So let's put it this perspective. You wake up in the morning, your sugars are high, that's fasting hyperglycemia. Day to day, your average is high, that's HbA1c. And when you go to a restaurant, eat something, your sugars go up, which is the after glucose load. So which one of these will be the most significant? I think fasting will have a significant implication. If your fasting is high, you need to worry. And this is particularly true, especially for GDM, where fasting hyperglycemia is also given a much more weightage. But they give equal weightage to all three. So if we talk about this, fasting will have the lowest sensitivity, but it will have a high specificity. So what I'm trying to say is that if your fasting is high, you are most likely to have diabetes, but fasting is low, you may still have diabetes. HbA1c has the lowest sensitivity. So many patients with type 2 diabetes may be missed if their HbA1c. So HbA1c below 6.5 does not rule out diabetes. This is an important thing to remember. And glucose load, of course, will have a reasonable sensitivity and specificity. The variability, of course, is much less for fasting because that's a fixed phenomena. You have not eaten anything for 8 hours, your reading will not vary. Now, after glucose load, there are so many other factors which may play. And HbA1c, if you use a very good test, you will have less variability. But that has to be standardized against the DCCT. So this is an important factor to remember. So both of them are for fasting and HbA1c for screening, while after glucose load is more for confirmation and high suspicion where you do. So most cases of type 1 diabetes, of course, you don't need a glucose tolerance test, but obesity you would need from that regard. Now, very important is that you just not focus on glucose, look at lipids, look at blood pressure, look at ALT, other complications also. You have to look at it, and that becomes important. Now, in this case, fasting is 96, HbA1c is 5.3, and after glucose load, it's 123. So all is normal. So the next question is, what do we do in this obese child who has come to us? So the recommendations are that you don't stop there. You have to follow them up. And after at least 3 years, we would typically do every year, but they have talked about minimum every 3 years is important to do the assessment, and that will become important. Now we have a 16-year-old boy with polyuria who had a blood sugar which is very high, 440. HbA1c is 10%, and there is mild ketosis, no acidosis which is there. Diagnosed as DKA, insulin was given with requirement came down over time, and he also was obese. There was a strong family history of diabetes. There was acanthosis nigricans. So now the treating physician had thought of a possibility that this is actually type 2 diabetes, not type 1 diabetes. So in this scenario, what do you think would be important from that perspective, Dr. Vibha? What do you think? Is this type 2 diabetes? Based upon this information, would you call this type 2 diabetes?
The patient has high accuracy, ketones positive. This patient is behaving more like a type 1, but the insulin
requirement, now he is not requiring any insulin. He is off insulin. As soon as you started metformin, he is off insulin. He is on the obese side. There is a family history. So it is mostly type 2 diabetes. Do you agree with this management? Is there something wrong here?
We should not completely stop.
So what should be done before you stop insulin?
We should go for the GAD antibodies.
So that is the biggest thing to remember. That's a very big message. And if you look at the criteria for type 2 diabetes, what they say is very important. You talk about all that fasting, PP, HbA1c. This line is very important, negative islet autoantibodies. So unless you have excluded a pancreatic autoimmunity, do not label somebody as type 2, because obese type 1 will behave like the same. And if you stop insulin, they will develop DKA later on. So this is again a message which is reiterated very clearly, that if you're diagnosing type 2 diabetes, always consider that our islet set antibodies, GAD antibodies are negative. So this child was GAD positive, insulin should be continued. So this is a message which is now very, very clear, which is coming from the guidelines. Now, regarding classification, we already discussed that it based upon various factors. If the onset is before 6 months of age, we talk about neonatal diabetes and genetic testing. If the onset is after 6 months, and if there is decay and persistent insulin requirement, that is type 1 diabetes. If it's not, then you do a GAD antibody to classify a monogenic form versus the genetic form in that perspective. If after 6 months of age and you don't have any decay, GAD is positive, it is type 1. Otherwise, based upon obesity, you can classify into type 1 and type 2. So very importantly, GAD antibody comes high up in terms of suspicion before you label anybody as type 2 diabetes. Now, 9-year-old girl with obesity, and in this scenario, she is quite obese. HbA1c is 6.5%. Blood sugar fasting is 90, 2 hours is 120. So your HbA1c is slightly high, but fasting and 2-hour values are not that high. So what do you do if there is a conflicting result between two different parameters? And this is very, very common. Now remember, in this scenario that HbA1c, as I said, it has got less sensitivity. But if you are not measuring HbA1c using a standardized assay, you would have confusion in terms of making the right diagnosis. So what the guidelines say is that point of care test should definitely be avoided. It should be done via a lab which is validated against the DCCT standard. It is very, very clear. So in this case, repeat HbA1c was normal. So now on follow-up at 1 year, fasting is 128. So we have to follow up. Fasting is 128, 2 hours is 230, and HbA1c is 7.2. So now this patient at that time was not having diabetes, has now emerged into diabetes. Now, before we go into that, if there is a discrepancy between parameters, the guidelines basically say is that you repeat the parameters. And in the same test, if two parameters are positive, so let's say fasting is positive and HbA1c is positive, then you take it fine. Or in two tests, in first test, your fasting is high. In the second test, your 2-hour value was in the diabetes range. You can then assume it to be positive. If only one is positive, do not consider that. However, if there is discrepancy between the two, you consider the one which has a higher value is more significant, because that you don't want to miss diabetes. That's a basic message from that perspective. So now based upon that, what sort of lifestyle measures should we choose? And most of us are aware about that, but the guidelines talk about very clearly that mainly would be eliminating sugar intake, reducing high fat and calorie intense diet, talk about portion size, meal from outside should be repeated, regular meal, family meal. So general ideas are the same. Physical activity, at least 45 minutes, 3 days a week, reduction in television viewing time and sedentary activity, and very important emphasis on sleep, approximately 8 to 11 hours, depending upon the age of an individual. So these general measures are important, but these general measures are not going to give you a huge reduction in HbA1c. So if your HbA1c is already 7.8, do not rest upon these general measures. So what should be your goal? And that will tell you as to when these general measures may alone be enough. So for goals, what the recent guidelines are very clear. They're talking about absolutely normal levels. Now, Dhani, what do you think? Is it easier to get good control in type 2 in adolescence or type 1 in adolescence? Which is easier to achieve good control? Yes, because they have good amount of insulin. It's just a resistance, so you will have a good control. But type 1, you can't have the same control in that perspective. So what they're talking about is absolutely normal. Fasting 70 to 110, post meal 70 to 140, and HbA1c less than 6.5%. So the guidelines clearly talk about very, very strict control as far as these sugars are concerned, and this is usually achievable. Now let's go about, we've talked about lifestyle, we've talked about making a diagnosis, we've talked about the goals. Now, how do we manage that? So we have a 18-year-old girl who basically had a fasting level, which is 188, and 2 hours is 340. HbA1c is pretty high, ketones are present. She is obese with acanthosis. So as I said, at the presentation, you may not know whether this is type 1 or type 2, but then you have to make a decision about how to go forward in terms of management. Her C-peptide is on the higher side and GAD is negative. Now, how would you manage in this scenario, Dr. Vibha?
This is like patient is having high HbA1c, so only the lifestyle modification will not be enough. You have to go for.
So you have to go for pharmacotherapy, definitely. Which pharmacotherapy? Yes. So if somebody is ketotic, I would be very, very wary in starting metformin, because in ketoacidosis, metformin can worsen. So this you have to manage as any type 1/DKA, look at blood gas and everything. And then after 2 to 3 weeks, you start that in that perspective. So if you now look at what the options we have is, we can either decrease the hepatic glucose production using metformin, We can use thiazolidinediones to increase the muscular uptake, which is the PPAR gamma agonist. You can use GLP-1 receptor analogs to decrease gastric emptying, insulin production, decrease glucagon production, and induce satiety in the brain. You can use DPP-4 inhibitors again to prolong the effect of GLP-1. You can use glucosidase inhibitors, which can decrease the glucose absorption from the intestine. You can use the insulin, of course, which is the clear-cut final replacement, or you can use the other parameters. So now what are the agents which are clearly cleared in adolescence? We all, of course, know that insulin and metformin are the mainstay. And now we have GLP-1 receptor analogs, which are being recommended in a better way in most perspective. So now what the guidelines say is that anybody in which the HbA1c is in a reasonable range. So if your HbA1c is less than 8.5%, you should start with metformin alone as a good therapy. Now, when do we get that sort of figures? This happens when you have a child who comes to you for the first time, you're evaluating for obesity, then you get it done, then you will find it. Anybody who comes to you who is symptomatic, usually the HbA1c is beyond this level. So what I'm trying to say is that in the acute stage, one, you are not sure whether this is type 1 or type 2. And second, your HbA1c levels will be beyond that. So then insulin becomes important. Regarding insulin, they say that if there is ketosis, ketonuria, or acidosis, and A1C above 8.5, insulin is absolutely important. Now, if somebody is in frank decay, they haven't mentioned in as many words. If somebody is in frank decay, start basal bolus. If somebody has mild ketosis like that girl, you may start with a basal insulin because that will supplement the perspective also from that regards. Now, what they say is that once you start insulin, 2 to 6 weeks, you can start thinking of adding metformin. Be wary if there is acidosis. I don't want to start because I can precipitate lactic acidosis. But if you have a good response, 2 to 6 weeks, you start metformin. And we have just seen last week how those two girls responded very well with metformin. And suddenly the requirements will come down and you will know this is type 2. But before that, you should also have the GAD antibody done. So by 2 weeks, you've got those results done. And then you start using that to reduce the insulin requirement. So just to summarize, based upon the guidelines, if there is a non-osmotic symptoms, HbA1c is less than 8.5%, start metformin. If there's improvement, you continue. We have seen that approximately 20 to 30% patients may even come off metformin as well. But all of them, if they do not control their diet, will go back in terms of developing diabetes. If there is no improvement with metformin, in this scenario, now we tend to go more with GLP-1 receptor analog, although basal insulin is also an option. If, however, there is osmotic symptoms, A1C is more than 8.5, but there is no DKA or honk, you can give basal insulin and metformin together, and you can go up to 1.5 unit per kg per day. Then you think of prandial insulin. Insulin therapy without sensitization is difficult because their insulin requirements may become very, very high because of insulin resistance. Now, if there is improvement, you can taper metformin. Here also, you may think of GLP-1 receptor analog as an option if your requirements are very, very high. However, if somebody is DK or honk, you start insulin and then gradually add metformin to see for improvement and then go from that perspective. The guidelines say if your target of 7% at least, so 6.5 is the ideal, 7 is the upper limit, then you think about second line agent, which becomes important. And if your HbA1c becomes worse, more than 10%, consider adding a basal insulin. So these are the general guidelines. So these are the two new parameters that we have talked about. If HbA1c is more than 10% on follow-up, think of a basal insulin. My take would be, if you're not responding to metformin, please consider a GLP-1 receptor analog if the patient doesn't have any significant osmotic symptoms on that perspective. So now if we go back to this scenario, we have got a girl who has got ketosis, which is clearly there. So in this scenario, of course, we have to start with a basal insulin and metformin. And she was started on glargine and gradually she responded well to metformin. So this will be the way which we have adapted from the guidelines. Now, on follow-up at 12 months, she had poor adherence, now has weight gain, HbA1c is 9.2% and SGPT is high. So steatohepatitis is happening. What do we do here? So as I said, again, we have got this worsening which is happening. So either you go to basal insulin or you think about a GLP-1 receptor analog, and the injectable preparation liraglutide is clearly approved in children from that regards. So metformin was increased in GLP-1 receptor analog, which will reduce weight, will have a beneficial effect on steatohepatitis, and will also improve the glycemic control. So this is the way forward from that regards. Now, what about complications? And we know that type 2 diabetes causes huge number of complications, including hypertension, dyslipidemia. For these, you have to measure blood pressure at each visit and lipids at diagnosis and annually. Nephropathy, albuminuria should be done using 3 first morning collections, and then you assess from that. Retinopathy at diagnosis and at follow-up. So the big difference between type 2 and type 1 is that 30% children who have type 2 diabetes have one complication or the other at the time of diagnosis. So you have to assess, you don't wait for a long time. Why? Because it's a long-standing disease. It's not just a short-acting disease. Second, after puberty, the complications increase even in type 1. So same will apply here as well. Neuropathy, also food examination becomes important as per the guidelines. Think about PCOD, ask about menstrual history, hirsutism, acne, and other parameters, and always measure steatohepatitis. And I would basically be focusing on these 3: hypertension, dyslipidemia, and nephropathy, because these are the ones which we see most common. So blood pressure should be measured at every hospital visit, and we all know that you've got those guidelines based upon which you can classify the various forms of blood pressure. Ideally, they say you can measure it through various options, but if you are using a sort of an automated device, if it's abnormal, measure again via the cuff. And they also talk about the role of ambulatory monitoring if you have doubt about the white coat hypertension. Now, echo, this is a new guideline which says that individuals who have got significant hypertension, you should get an echo to look at a cardiac effect of that hypertension. Initial management, of course, is the nutrition approach, low salt diet, followed by, they talk about monotherapy with ACE inhibitors. If that is not working, you can think about ARBs, you can think about CCBs, calcium channel blockers, and diuretics. So this is the basic sort of a protocol. So blood pressure, you have to monitor at each visit. If it's elevated or stage 1, you mainly focus on salt restriction and lifestyle measures, which becomes important. If there is no improvement, or if you are stage 2 to begin with, start on ACE inhibitors. If there is no improvement, the options are 3: ARBs, thiazide, and CCB. So most of us will be thinking of perindopril, lisinopril, these sort of drugs we start off from that regards. What about triglycerides? So this again is an important factor with regards to the lipid abnormalities. So now we have got a 16-year-old girl whose cholesterol is 240, LDL is also high, and triglyceride is also high. So now, Vibha, this patient has just been diagnosed with diabetes, and she has been advised statin. Do you agree with that or not?
So we don't advise statin because triglyceride is
So LDL is 180.
what is the non-HDL level?
So LDL is 180, so non-HDL will be high only. So I think the major question you will ask is, how long has she been off the diabetes diagnosis? Has her sugars been controlled or not? So you should not do a lipid profile before they actually achieve a metabolic stabilization. So that's very, very important. So as you said, should be achieved only after glycemic control has been achieved. So do not do a lipid profile at diagnosis. You will get a high reading anyway. And then after 3 months, once you have done that, then you don't wait. So in the initial phase, you will say, okay, lipotoxicity. Like you have glucotoxicity, lipotoxicity is there. But after 3 months, whatever, you can check that. That is the important factor to remember. Now, what they say is that if your levels are above 130 for LDL, you have to start targeting. And HDL, there's no specific treatment for HDL, but less than 35, you are a bit worried. And TG levels more than 400 would be a cause of concern. So this is what you need to understand in terms of their guideline levels on that perspectives. And they say that if you have persistent levels of elevated LDL beyond 130, you should start with a low dose statin. Low dose will be like 10 milligram of atorvastatin and 5 milligram of rosuvastatin, which can then be built up subsequently. The problem is once you start statin, when to stop. In females, it is a big issue because ultimately it is going to cause a lot of problems in terms of teratogenicity. So you have to be cautious in not starting in everybody with statin. But yes, type 1 diabetes or type 2 diabetes in this young age is in itself a cardiovascular risk factor. You have to consider adding statin at some point. So if your LDL is less than 100, nothing to worry. 100 to 130, go for lifestyle measures. Improvement, you continue. No improvement, then you go ahead with statin. Start with low dose. If there's no improvement, go on higher dose. And if there's no improvement, think of ezetimibe and other group of agents which decrease the gastric absorption also from that perspective. And of course, you have to look at specific guidelines which are there, the child 2 guidelines about cholesterol, fat, and other intake, as well as statin. Start with a low dose, 5 milligrams of rosuvastatin, 10 milligram of atorvastatin, and target LDL below 100. So these are the basic guidelines which are there. Triglyceride is usually going to cause a concern if it's beyond 1000. That is the time when they will cause pancreatitis. But here above 400, you have to consider adding fibrate. Generally, do not combine rosuvastatin and fibrate in children because both can have hepatic issues. So we have to be cautious in that regard. So that's what they're saying. Statin plus fibrate combination should be preferably avoided. Now, 16-year-old girl diagnosed 2 years ago. Now, urine ACR is 380. What would you do in this scenario, Dhwani? So what could be the possible causes that in this girl, your urine ACR is very high, false positive? Anything especially in girls?
She is obese and she is.
Vibha?
But she is menstruating.
So close to menstruation, your levels will be falsely high. So everything else is normal and suddenly you find this level and parents become really concerned. So what they say is that it should not be only a single reading. You have to do multiple readings to make a diagnosis. And levels, of course, 30 to 300 is significant, in which you need to do a ACE inhibitors, BP control. But beyond 300, you have to think of whether it's really positive or not. But if within 2 years, urine albumin is more than 300, it is not nephropathy. You have to start thinking of alternate possibilities. Somebody having nephrotic syndrome, somebody having whatever. You have to refer to the nephrologist from that perspective. And very importantly, when you have started ACE inhibitor or ARB, you have to look for urine albumin within 6 months. Now, what would you do? Well, suppose you start her on ramipril. What test would you like to do after how many days to exclude any complications of that drug?
Serum electrolytes to look at hyperkalemia.
Serum electrolyte and creatinine. Sometimes if there is some the blood flow is less, you may cause worsening of renal function, which you have to be aware about. Now, 16-year-old girl with other parameters. Now, what was there that she was having menstruation recently, and that was the cause of false positive cause of that. So this is something you have to be wary about. So not every single reading, don't get too much psyched about from that perspective. Repeat was normal in this regards. Finally, about steatohepatitis, and we have seen in obesity that steatohepatitis is a major problem. So in diabetes also, it becomes a problem. So you have to measure. Now, big issue is that suppose your ALT level is 70 or 80, whether you start metformin or not. Because metformin is known to cause hepatic, and hepatic dysfunction is a contraindication for metformin. So generally, this is because of steatohepatitis, metformin will improve that. So unless the levels are 3 times the upper limit, do not give metformin. So if it's more than 120 or something, then I'll be worried, but otherwise I will not be worried. If they are more than 3 times above, this is what they have said, you have to think of other causes. So you have to refer to a gastroenterologist and do not start metformin in that perspective. And very importantly, this is often people have a question and they have given a very clear-cut answer that if you have NAFLD, does not exclude the use of metformin if your SGPT level is less than 3 times the normal limit. So what they have tried to do is to provide a guideline with regards to the diagnosis, lifestyle interventions, medications, complication assessment. So it's a very comprehensive guideline which are freely available on the ISPAD website. All of you should go and have a look at it The key takeaways are that we have to start early in terms of treatment. We have to look at HbA1c with a pinch of salt when you look at in terms of diagnostic classification. Metformin remains the mainstay, but there's an emerging role of GLP-1 receptor analog. We should have a low index of treatment threshold for starting insulin, especially in the initial phase, and monitoring for blood pressure, for lipids, for fatty liver, as well as for other complications is absolutely important. So this is what we try to cover from there. So now from too much to too little. So we have been talking about obesity. Now we will talk a bit about SGA babies who are not catching up. And this again is an important guideline which has recently come up from the international consortium which has worked on these guidelines. So over to you, Dr. Dhwani, who will be focusing about this from that view.
Thank you, sir. So before this, the SGA guidelines for growth hormone was last seen and published in 2006, and this is the update to that study. Why do we need this study? We know that SGA is birth weight or birth length less than -2 standard deviation for gestational age, and we need to know whether or not a child is SGA because it has implications at each stage of life, not only in the neonatal period where it has a higher risk of hypoglycemia and hypothermia, but in the children and adolescent period where SGA, children born SGA have a higher risk of persistent short stature, and those with a rapid catch-up may have insulin resistance, increased fat mass, a lower lean body mass, and lower bone mineral density, which ultimately leads to a higher risk of cardiometabolic complications in the adulthood period. There have been no clear universal guidelines about how to monitor these children, what protocol to use, what other diagnostic tests to do, and about the growth hormone therapy in these children. Let us have a look at these guidelines through examples. So we have a 2-year-old boy with poor growth. On history, there was no history of systemic illness and no history of pica and was developmentally normal. On inquiring further, we found that he was born at 32 weeks with 1.6 kgs, had an echo stay mainly to establish feeding, but otherwise had no hypoglycemia or hypothermia, no complications during the neonatal period. This child at 2 years had no syndromic features on examination and had no features of macronutrient deficiency. His weight was at -1.5 standard deviations and height at -2.3 standard deviation. The attending physician went ahead with screening investigations, which were normal, and decided to start the child on growth hormone therapy. Now, what we need to understand here is that 1.6 kgs at 32 weeks was actually an AGA child. So, the guidelines recommend an accurate classification of SGA, preferably to use national growth chart so that bias is avoided. And this child on follow-up had normal catch-up without growth hormone therapy. Looking at another example, so we have this 2-month-old.
That's a very important message that we should not assume that somebody is SGA. Always look at our own chart. So which charts would you recommend?
Intergrowth 21 charts are used to monitor the fetal growth.
And they would be definitely recommended.
Yes. So we had this 2-month-old child who was brought in for a routine vaccination visit. We found that there was a history of antenatal maternal anemia and preeclampsia, and the child was born at term with weight of 1.7 kgs. Now, at 2 months of age, the child had a weight of 3.6 kg at -3.3 standard deviation and a length of 52 centimeters at -3.2 standard deviation. The head circumference was also on the lower side at -2.3 standard deviation score. So now that we've identified that this child was on the lower side, this child was definitely an SGA, what do we do? How do we go about? So the guidelines recommend that the first step, of course, here is that you prevent from developing an SGA. So in the antenatal period, the mother should have received good antenatal care, frequent monitoring and ultrasound examination to pick up abnormalities and received proper care. After that, every child who was born in SGA should be carefully followed in the first year of life by a neonatologist or pediatrician to evaluate growth, weight gain, and neurodevelopment. And these trajectories should be followed to identify malnutrition, growth faltering, or early excessive weight gain catch-up. So that's how we went ahead. In the next visit, at 3-month visit, we found that his weight was at 4.9 and length at 57.6. So from the previous SG scores, he has definitely in the plus 0.2, 0.3 gain we could see. But the attending physician saw that the child was still at -3, so he advised formula feeds for this child. So the guidelines mention that the best for these children to not have an excessive weight gain is that they continue breastfeeding for 6 months of age. It is recommended to avoid additional nutrition supplements in these children, except when you see obvious clinical features of malnutrition.
Why do you think breastfeeding is important in terms of this first 6 months?
So breastfeeding will allow a normal weight gain and will prevent an excessive weight catch up in these children.
And it's very clearly shown that exclusive breastfeeding in the first 6 months of life is a known protective factor
For the
subsequent obesity,
Yes.
type 2 diabetes, PCOS, so everywhere
Yes.
it has been shown. These children who are already, there are two groups of children, one who may develop too much and they will develop complications, and one who will develop too little. So there definitely breastfeeding is something which is very important to follow.
And moving on, so looking at the recommendation for follow-up, weight, length, head circumference, and weight for length should be monitored every 3 monthly in the first year of life, every 6 monthly in the second year of life, and annually thereafter.
This is pretty much for
Yes,
every child.
every child,
So this
yes.
is not even for SDA, but definitely more for them.
Yeah, so this is how we went ahead with this little boy. On follow-up, we found that by the age of 1 year, his weight centiles were definitely crossing lines, whereas his height centile remained parallel to the third centile line. So it is important that in children born SGA, an excessive postnatal weight gain should be avoided, since it is associated with a less favorable cardiometabolic risk in the long run. And what is more important, although not something we would look for in a 1-year-old child, but just crossing our weight centiles should not be the reason where we go ahead with glucose profile and lipid profile in these children. So assessment of fasting glucose and lipid concentration is recommended in SGA children only when they are overweight or obese or have clinical features of metabolic disease with positive family history.
What would be the first sign that your child is actually going towards the obesity? One, of course, is this. If you look at the BMI, there is any way which can tell you. So normally we see that the BMI comes down and then it goes up.
Yes.
So this is known as obesity rebound. So if the obesity rebound is happening earlier, it is an indicator that this child is going to develop a lot of metabolic complications.
Okay.
So that obesity rebound also is very, very important. Carry on.
And as per the recommendation, we kept following this child. So we found that at 2 years of age, his weight had pretty much stabilized, but his height remained parallel to the third centile curve. So catch-up growth is defined as any growth more than 0 standard deviation or more than median for chronological age and sex. When a child born SG has persistent short stature, that is less than -2.5 standard deviation by 2 years of age, or less than -2 by 3 to 4 years of age, without signs of catch-up in the last 6 months. That is the point where you should refer these children to a pediatric endocrinologist.
This is an important guideline. Before that, we used to say 2 to 4 years. It's a bit
Yes,
it was based upon the growth hormone starting indications.
Yes.
So like there are different indications in US and Japan, which we'll talk later. But this very clearly says that the quantum of growth failure is also important. So if you are much more compromised in younger age, you don't need to wait from that perspective. Frankly speaking, most children, 90% will catch up by around 18 months. So 2 years itself is a bit late, but this is fine. If you're just between 2 and -2 to -2.5, you can wait. But otherwise, this becomes enough.
Yes, so as sir has mentioned, the American guidelines have a cutoff of 2 years of age, wherein they also start in growth hormone therapy. But in the low to middle income countries, because there are so many other confounding factors responsible for a poor catch-up, it has been advised to wait for a period of 3 to 4 years. And by 4 years of age, by the time the child presented to a pediatric endocrinologist, his height was 92 centimeters, which was -2.7 Z scores, -2.7 standard deviation, and weight was at 15 kgs. He had no obvious dysmorphism and general systemic examination was normal. The screening investigation was normal. So what do we do? Where do we go from now? Let us look at the recommendation. So an SGA with short stature. So height at -2.7, he is definitely short stature. One must ensure that they use age, sex, and population specific growth charts. Using WHO growth charts for an Indian population may falsely classify our children as short stature, and therefore it is important to use ethnicity.
But at 4 years, you'll be using WHO.
So, I mean, sorry, yes, you will be using.
Yeah. But in
Yeah.
subsequent districts, you
Yes.
should look at local regional charts.
Yes.
Reputable.
Another important thing that this recommendation guideline recommends is that any child born very preterm, less than 28 weeks or severely SGA, one must always keep a high index of suspicion for syndromic short stature in these children and actively look for dysmorphism, look for skeletal dysplasia or a disproportionate short stature as simple markers that microcephaly, intellectual disability. So these are the subtle things that one has to be looking for when you look at very preterm or severely SGA children.
I mean, this is important that you have to think of syndromic causes. There are two reasons. One, the responsiveness may be different.
Yeah.
And second, which we'll discuss subsequently, whether there are contraindications to growth hormone therapy, which also may become relevant.
Yes. So in our index child, we've seen that examination was normal, initial screening tests were normal. So what endocrinological workup is needed? So we need thyroid profile and IGF-1 levels at outset, and IGF-BP3 levels only if IGF-1 levels are low. Growth hormone stimulation test is only indicated in those suspected to have a growth hormone deficiency. And while this holds true clinically, the Japanese guidelines recommend a growth hormone stimulation test in all these children, because if found to have low growth hormone levels, then one can start growth hormone at a lower dose as compared to those for
I
estrogen.
think this is a very important issue. Now, if you are not doing growth hormone stimulation test, why are you doing an IGF-1 also is a questionable thing. So IGF-1 is just a screening test.
Yes.
So they ultimately say if IGF-1 is low, then you do IGF-BP, then what does it make a difference? So generally, if at all, one really, if you talk about the cost effectiveness of evaluation, if you want to do a growth hormone stimulation, go for a stimulation. Because stimulated growth hormone is an important indicator of responsiveness to growth hormone. And that's what Japanese studies do. Otherwise, IGF-1 itself is also not, is superfluous. It's not going to make a difference unless you think this is GHD. How will it help otherwise?
Will basal IGF level help us in subsequent monitoring?
So how will it help? Because your aim is not the delta IGF-1. You're looking at how much is the absolute IGF-1.
Okay.
So you want the absolute IGF-1 levels to be in the normal range, not that the increase is this much. So that's why I said guideline does not mean that you have to follow everything. You have to think of what is best for your own scenarios. Yeah, please carry on.
And another thing that the guidelines, which was previously not mentioned in the guidelines, was what genetic workup and who do we go ahead for genetic workup. So if you have a child, so in any short stature, we know that we look at the upper segment, lower segment ratio, we're looking at microcephaly, we're looking for dysmorphic features. So if you have a child with body disproportion or skeletal deformities that you can identify, then you go for a skeletal survey. Refer to a geneticist if applicable in your clinical scenario, and subsequent genetic tests may be required for confirmation of diagnosis. If you have abnormalities in the GH IGF-1 axis and or IGF-BP3 levels, then you need to go for specific genetic tests to make a diagnosis in this scenario.
Yes, if you are looking at a severe IGF-1 deletion, IGF-1 resistance, which is exceedingly rare, there definitely the role will play, but not for everybody.
Yes.
I think that will be.
If you have dysmorphic features, microcephaly, developmental delay, intellectual disability, and or major malformations, you're looking at a syndromic short stature. The subsequent tests will depend on the phenotypic characterization of this child, and one may consider referring to a geneticist. If it is a known genetic syndrome, then you go for a specific test. If it is an unknown genetic syndrome, then you go for whole exome sequencing, whole genome sequencing, whatever is clinically
Now the big question which is there is, do we need to do genetic testing in everybody to exclude the contraindications with GH therapy? That's a big question. What do they say on that? So they have
There
a
was,
picture in
yes,
everybody.
there is.
Because there is a debate whether everybody should have a NGS before not easily available. You don't want to give treatment in those who are not really not candidates for GS therapy. So if you are thinking of GS therapy, this is something which may come up,
Yes,
whether you want to do it or not.
In the last subcategory where you have no other features suggestive of a syndromic short stature, you're looking at idiopathic or isolated short stature. So here karyotype is advised for girls, and one may consider growth disorder panel or whole exome
So
sequencing.
ultimately, in everywhere they're talking about
Yes.
genetics.
Yes.
Whether you had features, they don't have features. So it is not going to make up. So this
Yes.
algorithm, although it is an algorithm, it
Yeah.
really ultimately leads to the same thing.
Yeah,
That you have
use
to
your
think of,
clinical.
and then you have to look at genetics everywhere. Genetics are coming
Yeah.
up on that. But definitely, we should not go for genetics like for diagnosing GHP. Like we have seen patients in the genetics of things, but this is the way things are going forward. Carry on.
So in this index child, based on the recommendation, we went ahead with thyroid profile and IGF-1 levels, which were in the normal range. So looking at growth hormone therapy. So you have a short child, you're thinking of growth hormone therapy, but does it really help in the long run? So we have seen that the growth hormone therapy helped with normalization of adult height. It helped decrease the fat mass, improve lean body mass. However, it does increase insulin resistance to some extent, but there was improvement with the blood pressure profile and improvement in the bone mineral density and psychosocial functioning. So how much or who is a candidate? It is indicated for persistent short stature at any age after which catch-up growth is unlikely, which, as sir has mentioned, usually it happens by 18 months of age. So 2 years also may be late, but in low to middle income countries, it is recommended after exclusion of all other criteria of all other confounding factors by 3 to 4 years of age. So we've already seen when to start it and when not to. So growth hormone therapy is not recommended in several genetic disorders that have a predisposition to develop cancer, especially chromosomal breakage syndromes and DNA repair disorders. And as I've already mentioned, growth hormone stimulation therapy is not recommended before starting growth hormone in all these children. How much to start it with? So the growth hormone dose recommended is 33 to 67 mics per kg per day. It is preferred to start with at a lower dose and then subsequently increase based on the clinical response in children. A higher starting dose within this range may be considered in those with marked growth retardation.
And those who are diagnosed, those presenting late.
And those
like most of our
yes.
patients may actually be coming at 8 years, 9 years, near puberty. So that is the time you have to give a higher dose, maybe preferable. So 67 microgram per kg per day is a big dose.
Yes.
It is very, very big dose. So generally we'll start by around 0.33 is good, maybe up to 40, but that's the upper limit.
Yes. And they've also mentioned that starting upfront at 67 is not recommended. So IGF-1 levels are subsequently monitored to look for adherence and for safety profile. And growth hormone dosing based on IGF-1 titration alone is not recommended. One has to look at the clinical benefit that it offers.
So basically, if you titrate, there is one study which was looked into the GHD group. If you titrate based upon the IGF-1 level, your dose becomes 3 times. So if you're giving 30, it becomes 100 to get the IGF-1 high. Now, everybody with the same IGF will have a different response because the receptors are also different. So it is of no sense to use the IGF-1 for titration.
Right. And while on growth hormone therapy, one needs to monitor weight and height at each visit every 3 to 4 monthly during growth hormone therapy. Sitting height is necessary for initial because there may be syndromic forms of short stature who may or may not benefit or who from growth hormone therapy. So it is at the start of therapy, one needs to look at the sitting height, blood pressure. That is again recommended at each visit, Tanner staging at each visit. IGF-1 levels is something I wanted to point out is it is advised at start of therapy and then annually thereafter. Thyroid profile is recommended at start of therapy and annually thereafter. Lipid profile is not recommended unless clinically one sees an overweight or obese child, but subsequently at cessation of growth hormone therapy, one needs to get the fasting lipid profile. fasting glucose, insulin, HbA1c again at the start of growth hormone therapy and subsequently if clinically indicated. Another thing that I wanted to highlight here is bone age. We know that SGA children have a higher risk of precocious puberty by about 5 to 10 months before the AGA children, and have a rapid progression of puberty. So bone age, although not routinely recommended, especially not in the pre-puberty children, but by 8 years of age, it is recommended that one get an annual
The
X-ray.
reason that they have to put bone age a bit down is that the reliability of bone age in SGA is less, because many of them have skeletal abnormality. So you cannot really reliably judge the bone age. But yes, of course, because most of our patients are late, we have to monitor them very closely during puberty.
So our 12-year-old boy was started on growth hormone therapy and had shown improvement in the height, but we noticed that even by 12 years of age, his height was at 134 centimeters at minus 1.9 standard deviation, whereas his mid-parental expectation was at a higher percentile. His pubertal staging was already PhD with testicular volume of 4 cc, and a bone age was closely followed by at 11.8 years. So in this child, if even after increasing growth hormone dose, we saw that this clinical response was suboptimal, and especially now knowing that he may enter puberty and may have even less time, what do we do in this stage? Looking at the guidelines. So who is eligible for GnRH therapy? A growth hormone treated child born SGA who at the onset of puberty comes with an expected short adult height, or SGA children who were SGA who present much later, like sir has mentioned, who come later in puberty and have a less time for achieving growth hormone adult growth. GnRH therapy is recommended for a period of 2 years, and it is shown to increase height by plus 6.6 centimeters in boys as well as girls. Over the period, safety has been established for GnRH therapy along with GH therapy. However, significantly long-term studies are still needed.
So this is a new recommendation that
Yeah.
if you are short at onset of puberty, think of GnRH. This we were doing, but now it has come up in the guidelines.
So this child was started on GnRH therapy. Puberty was delayed, postponed for 2 years, and this had shown a significant improvement in the final adult height in this index child. Looking at when to stop growth hormone therapy, first is no response. When you see poor adherence or repeated non-adherence, that is the period where you should not go ahead with this, because French studies have shown that in SGA children who were started on growth hormone therapy for a period of 3 years, and then when the therapy was stopped, they had shown a catch down growth. So in poor adherence or repeated non-adherence, one may not go ahead with growth hormone therapy, and when no clinical benefit is seen in a child. The other point where you stop growth hormone therapy is when adult height is reached. That is when the rate of growth is less than 1 centimeter in 6 months and with clinical evidence of closure of epiphysis. In this, SGA child started on growth hormone therapy. In the adult run with growth hormone therapy, there was what you've seen as a normalization of adult height with a decrease in fat percentage, increase in lean body mass, improvement in bone mineral density. Insulin sensitivity improves after stopping growth hormone therapy in the long run. And as far as the studies have shown, followed up for 5 to 12 years, growth hormone therapy has been shown to be safe in the long run in the improving the cardiometabolic profile in these adults. So upon discontinuation of growth hormone therapy, adults born SGA should be counseled to adopt a healthy lifestyle, because we know they are at a higher risk of cardiometabolic complications, and long-term follow-up of previously SGA adult is recommended to identify those with risk factors. So the take-home messages are follow up early, timely referral to endocrinologist when you see a faltering of growth, avoid excessive weight gain. New genetic causes of short stature are increasingly being found and should be actively looked for. The dose for growth hormone is 33 to 67 mics. Start at a lower dose and build it up if clinically need be. and routine health surveillance is not needed in all adults, but they should be encouraged to adopt a healthy lifestyle.
So I think that's a wonderful discussion with regards to this important topic about the short SGA. And this really has a lot of relevance because of so many new developments which have taken. We'll take a few questions before we start the final session. We've got a few questions. Pre-diabetes more obese than diabetes. True, Dr. Panaliram. Dr. Edley is asking, my question is, child with CKD, for how long he will benefit from growth hormone therapy if doesn't undergo kidney transplantation? It's not recommended at all because this is going to cause more problems from that perspective. So we should avoid that. I have an 18-year-old girl, Dr. Edley, again from Cameroon, Turner syndrome with a delayed bone age of 6 years. Is she eligible for GH therapy or is already late? So if the bone age is so delayed, she can definitely benefit from growth hormone therapy. So I think we will continue with our final session, which will be about a very important topic of gender discordance. And often we are now seeing patients who are presenting to us with issues with regards to the gender identity. And there's so many issues involved as to what should be done, who should be the primary person who should evaluate that particular scenario. How do we go forward and what should be the evaluation approach, and what very importantly is the endocrine parameters to do and what treatment can be done. So I have Dr. Vibha who will be talking about these topics and in detail. So over to you, Dr. Vibha, on this topic of endocrine treatment of gender dysphoric children.
Thank you, sir. Good afternoon, everyone. I'm here to present the endocrine treatment of gender dysphoria by the Endocrine Society. So let's begin with the recently encountered very interesting case of a 22-year-old female who visited to our OPD with the complaints of a discomfort in relation to her body since childhood. She described her gender identity as definitely not as female. She has consistent feelings of a more masculine identity. Her breast, her voice, menstruation, and misgendering as female were the main sources of her mental distress. So the main question that came to my mind during the OPD session was, what should I do? Because this was the first case I was looking into, and how should I manage this case? So, and is it really gender dysphoria, or is it some other psychiatric condition similar to the gender dysphoria? So the guideline clearly says that a diagnosis of the gender dysphoria should be made by a trained mental health practitioner. He should be competent in using DSM and ICD criteria for diagnostic purposes. He should be able to diagnose gender dysphoria and distinguish it from other similar psychiatric conditions like body dysmorphic disorders. He should be able to assess the psychosocially mental conditions of the patients. So let's see what are the DSM criteria for the gender dysphoria. It is a marked incongruence between the one's experienced or the expressed gender and primary and or secondary sex characteristics. A strong desire to get rid of one's primary or secondary sex characteristics and a strong desire to be treated as of another gender. So making a diagnosis of gender dysphoria, is it sufficient to start the treatment? Definitely not. The guideline clearly advised that the patient should fulfill the criteria for the treatment, and these criteria has to be assessed by the MHP, that is the mental health practitioner, and he has to confirm that it is a long-lasting and an intense pattern of gender dysphoria, and it has worsened with the onset of puberty, and there is no coexisting medical and social problem that could interfere with the treatment of the patient, and the patient is in sufficient mental capacity to give the informed consent to the treatment. And the patient has been informed of the effects and the side effects of the treatment, like the loss of fertility after the treatment and the options to preserve the fertility. And she should give the informed consent. So what about endocrinologist? The endocrinologist should agree with the indication of the GnRH agonist treatment, confirm that the puberty has started, that is the pubertal state should be greater than 2, and there is no medical contraindication to the GnRH agonist treatment.
So what are the usual hormonal profile in these patients? In terms of, do they have any abnormalities in hormone profile?
Sir, they have generally, if that our patient was a female, they will have normal menstrual cycle. Everything is normal, but their what they are not comfortable with their gender identity, with their gender assigned at the birth. They want to be treated like another gender. Everything is normal. Every sex hormone profile, every cortisol, everything is normal. But the psychosocially, they are not comfortable in their body
Very
type.
important point here is that they do not have an endocrine disorder. We do not need to do extensive workup
For this.
They are not DSD in that sense.
Their genitalia is absolutely normal. So our patient absolutely fulfill all these criteria. So we plan to start the treatment. But the question was, how should we approach the treatment? The guidelines clearly says that we should not start the treatment in the prepubertal period, because in the 80% of the patients, when gender dysphoria is diagnosed in the childhood, most of the patient, the diagnosis get reversed in the adolescence. So we should not treat in the we should not give hormonal treatment.
And the other big thing is that because of all this social media and other pressures, now people who do not have the gender dysphoria also assume
that as exactly.
So that is why psychiatric involvement becomes absolutely important. It's a big decision to take.
And it is also important to start the pubertal suppression in the early onset of the puberty, because some of the changes are very irreversible, like the advancement of the breast stages and the appearance of the Adam's apple, that couldn't be reversed even after the treatment. So it is better to treat after the tenor stage 2. So what molecules can we use? GnRH analogs are used to suppress the pubertal hormones, and this for the puberty suppression, leuprolide, triptolene, gosdril, hysterine. The same these analogs are used, like we used for the treatment of precocious puberty. The protocol is followed as same. It is given like in the interval of 12 weeks, and with a dose of same to 22.5, 12 weekly IM dose is given. The most important part is counseling. The patient should be counseled enough that there will be some physical changes during the treatment. There will be some and she should be asked like whether she has to continue with the treatment or she has to stop with the treatment. So we should
if you look at it, this is a phase-wise treatment.
Yes, sir.
So initially, first we have to make sure that there is no psychosocial. Once we do, this is a reversible form.
Yes, sir.
So you're just suppressing puberty for some time. And often patient may become problematic and okay, I don't feel comfortable, and then they decide that okay, my decision is not final.
Yes,
so
sir.
These things you have to do stepwise.
Yes, sir. So during the pubertal suppression, the monitoring is important. Every 3 to 6 monthly anthropometry, blood pressure and tenor stages is being monitored, and 6 to 12 monthly LH, FSH, estrogen, testosterone, and vitamin D levels are monitored, and every 1 to 2 yearly bone density using DEXA has to be monitored, because when we use GNR analogs, the sex hormones are being suppressed and it will cause bone demineralization. So bone density assessment is important. As Sir has already mentioned that it is a temporary suppressment of the pubertal hormones. It can be reversed at any time according to the patient's wish. It provides more time to explore their gender identity, whether they are comfortable with this kind of suppression without experiencing ongoing incongruent pubertal development, or they were comfortable with their previous identity. So it will provide some time for them to explore their gender identity. So what changes should we expect after the GnRH analog? So as it is a reversible suppression of the pubertal hormones, it will not cause the permanent suppression. It will only cause the breast tissue. The breast will become soft, like slightly atrophic. The menses will stop. And in boys, virilization will stop and the testicular volume will decrease. And there are some physical changes that are irreversible in boys. That is low voice, broad jaw, and thick eyebrows. So we counseled our patient that during this treatment, her breast will become soft and her menstruation will stop. So after the pubertal suppression, can we really start the sex hormone treatment now? Absolutely not. Again, the patient has to get a clearance from the mental health person whether she fulfilled the criteria for the sex hormone treatment or not. And the criteria for getting a sex hormone treatment is the persistence of gender dysphoria during the pubertal suppression. He or she is able to estimate the consequences of partly irreversible treatment, because when we start the sex hormone treatment, it will be a kind of irreversible treatment. And she or he has been informed about the irreversible effects and side effects of the treatment, like loss of fertility. And endocrinologist agrees with the indication of sex hormone treatment. And there is no medical conditions to the treatment. So when the patient fulfills all these criteria, then we can start the sex hormone treatment. So the next question comes, how should we start? How should we initiate the sex hormone therapy? The guideline clearly mentions that before starting the treatment, we should always evaluate and address the mental condition to the patient that can be exacerbated by the hormone depletion and the treatment. And they are, in the transgender female, when we give lots of estrogen, the thromboembolic conditions can be increased. The prolactin level can be increased. It can cause macroprolactinemia. In the transgender males, because of the high doses of testosterone, erythrocytosis can be caused. So we have to evaluate all these conditions. So how should we go forward? The plan in our patient, as she fits into the criteria of the transgender male. Transgender male is the gender assigned at the birth is female, but she is not comfortable as being treated as female and she wants to be treated as male. So she fits into the criteria of transgender male, and the plan is to give injectable testosterone, which is testosterone ethanoate, and we will give with a dose of 75 milligram 2 weekly for 6 months, as she is a post-pubertal adolescent, and will increase to 125 milligram and will give it to 2 weekly.
This is slightly higher.
Adult dose.
So
Yes, sir.
adult dose is roughly 100 milligram
Weekly. Yes,
so
sir.
it's a bit higher.
And if due to some reasons or very compelling reason, we have to start the puberty very early, like during 13 or 14 years, we can start with a very low dose, like 25 milligram 2 weekly IM.
Why have they given 2 weekly and not 4 weekly? They have any.
So they haven't mentioned.
Sir,
Sir, I think they require more hormone to suppress the endogenous estrogen or some like.
But they are already on GnRH.
Yeah. But,
they are on GnRH, and then you start the contra-sexual.
And once the adult dose is reached, we can shift to 12 weekly injection, that is 1000 milligram. And GnRH analog can be discontinued when once the adult dose of testosterone has reached and when they are individualized, well virilized. And if the uterine bleeding continues, even with the testosterone dose, we can add medroxyprogesterone with a dose of 10 to 10 to 20 milligram OD of BT.
So how would testosterone inhibit menstrual bleeding?
So it will
So why is there no bleeding in PCOS? It's the anovulation.
anovulation.
But the high testosterone will suppress the LH test.
Sir,
And
but
therefore you will not
I don't understand why even with the testosterone.
You can
have-
theoretically. Generally 99% will not.
Okay. In case if there is it would have been if in case of transgender female, the pubertal induction is done with a very low dose of 10% of the adult dose, and it is increased 6 monthly to reach the adult dose of 2 mg per day in 2 years. If it is a post-pubertal adolescent, we can start with a higher dose of 1 milligram per day for 6 months. Then we can rapidly increase it to 2 milligram per day.
You have to be cautious because high levels of estrogen can have a huge impact on the brain and
Brain as well.
There's a very interesting story about a famous scientist called Turing.
Okay.
He was supposed to be one of the most brilliant scientists of all times, and a lot of work was done on that. So he was basically had a criminal case against him that he was found to be homosexual. So even in 1945 or 47 in Britain, there was a rule that if somebody is found to be homosexual, they will be chemically castrated. So they used to give dihydroestylbestrol. So because of that, he mentioned that he had so much changes in his brain that he actually committed suicide. So this is something that this can have huge impact on the mood as well. So while it's very easy for somebody who has been influenced by the social media or whatever, that they are trans and they start estrogen, we should be very, very cautious. And that's why they talk about multiple steps psychiatric intervention. Because this sudden changes in your brain, your estrogen goes really high, it's never been exposed to those levels, can have a huge problem.
Yes, sir. And the monitoring during the induction of puberty is very important. The parameters that has to be monitored is the anthropometry, and that is to be monitored 3 to 6 monthly. Blood pressure, as this estrogen will increase the high blood pressure, even the testosterone. In the transgender males, the hematocrit, lipids, testosterone levels, vitamin D levels has to be monitored. And in the transgender females, prolactin, estradiol, and the vitamin D levels has to be monitored. And in both cases, bone mineral density has to be monitored by using DEXA. GnRH analogs are continued till gonadectomy in trans females. If trans female wish to stop the GnRH agonist, anti-androgenous like the spironolactone or cyproterone acetate can be used in its place. So what physical changes should we expect after the sex therapy? And what time will it take? Let's see. The education regarding the onset and the time course of physical change induced by the sex hormone therapy should be given to each and during each and every session. And it is the masculinizing effect in transgender females would be the first during the first 6 months. There will be skin oiliness, acne, fat redistribution, cessation of menses, clitoral enlargement, vaginal atrophy. And in the next 6 to 12 months, there will be facial and body hair growth, scalp hair loss, increased muscle mass, and deepening of voice.
So typically it will take around 2 years.
2 years lasted.
The other thing to remember that when you're analyzing them, many of them do not really want these sort of hormonal changes. They just want some basics.
Basics, yes.
So you have to ask what their goals are and then go about it.
And in the feminizing effects in the transgender females will be like in the first 1 to 3 months, there will be decreased sexual desire and the decreased spontaneous erections. And in the 3 to 6 months, there will be decreased testicular volume, increasement of the breast tissue growth, redistribution of the body fat, decrease in the muscle mass, and but there will be no changes in the voice. The voice will be same, and they has to take the voice therapy for the voice change. So how should we monitor?
They can be fertile for some time. This is an important factor to do.
Till gonadectomy, if you don't
Surgery is
till
done.
surgery, How should we monitor transgender persons on the sex hormone therapy on a long run? So in the transgender male, to monitor appropriate virilization and any adverse reactions, 3 monthly in the first year and 1 to 2 times per year. Serum testosterone 3 monthly, and it has to be done midway between 2 injections. The target level is 400 to 700. Measure hematocrit and hemoglobin level at baseline 3 monthly and then yearly. Monitor weight, blood pressure, and lipid profile 3 monthly. Screen for osteoporosis when they are non-compliant to the treatment and when there is a risk for bone loss. This ovarectomy can be considered after the completion of the hormone transition, and conduct sub and perioral annual blood examination if mastectomy is done, and if mastectomy is not done, then do the annually mammograms. In the transgender female, to monitor appropriate feminization, 3 monthly examination, 3 monthly monitoring is done in the first year and then annually. Serum testosterone less than 50 nanogram, and the target level of estradiol is between 100 to 200, and it has to be done 3 monthly. If on spironolactone therapy, then monitor the serum potassium levels 3 monthly in the first year, then annually. Routine cancer screening is recommended, BMD at baseline, and screen for osteoporosis, and periodically monitor serum prolactin as the estrogen administration increase the prolactin levels. So when should the genital gender affirming surgery should be done? Again, for the surgery, the individual has to fulfill the criteria. We cannot just advise just go for the surgery. There are certain criteria that has to be fulfilled, and they are persistent and well documented gender dysphoria, legal age of majority in the country, and having continuously and responsibly used gender-affirming hormones for 12 months, successful continuous full-time living in the new gender role for 12 months. If significant mental health concerns are present, they must be well controlled, and demonstrable knowledge of all practical aspects of surgery.
This is important. It's not a short
Short-term.
term. You have to tell them the people. It will take a couple of years at least to achieve that hormonal status, and then it may take 1 year more to further follow up. So this is a long-term therapy, and we have to decide what they really want, and then keep on having a regular follow-up with psychiatrist.
And the surgery that has to be done in transgender male is gonadectomy and hysterectomy if there is no plan for the fertility in the future. Mastectomy, reconstructive genital surgery. For the transgender male, for the transgender female, gonadectomy, removal of the penis, reconstructive genital surgery, breast augmentation, removal of the facial hairs, and the voice therapy is required. And endocrinologist should monitor transgender persons after gonadectomy for hormonal replacement. So now going back to the case, our 22-year female who was diagnosed with the case of gender dysphoria, yes, she fulfilled all the criteria for pubertal suppression, yes, and we started her on injection leuproid 11.25 milligram IM 12 weekly. Now our next plan, we are giving regular sessions for counseling. Now our next, after the complete pubertal suppression, our next plan, whether she fulfills the criteria for gender-affirming hormone therapy or not, and if she fulfills, our next plan will be to start the sex hormone therapy on her.
So I think this was a very good summary of the recommendation. The key message is that we need to be very careful about whether this particular individual who has come to us with gender dysphoria meets those criteria, and we don't get swayed by that. And then it's a stepwise process. Every step, our role is, if you talk about it's more like mechanical. We are just trying to suppress one hormone, adding another hormone. The key decision maker is actually the psychiatrist. So we are part of the team, but it's going to be not the main role. That is important. And a lot of people now are thinking that puberty blockers, as they are mentioned, GNR channel of people call puberty blockers are an easy thing you should do in everybody. We have to be cautious in that perspective. We'll take some more questions. How the less severe SGA behave compared to severe SGA? So the worse you are at birth, the likelihood of a pathological cause will be more, although there is no clear-cut criteria. But as Dr. Dhwani was talking about, maybe if you're below -3 SD, there's more chances of having some genetic causes. If there are asymmetrical IUGR, they are more likely to have a long-standing problem. So all those things will become important. Okay, so Dr. Tawfiq is asking, suppression treatment is recommended before puberty. Counseling will be given by parents. What if child changes his mind and complain that they have not consented for treatment? So this will depend upon the legal status of every country. We definitely see before puberty, why would you suppress is again a debatable issue. So we should really strongly discourage that. And even for DSD now, people are talking about that you should do interventions after they become mature. So this is a big legal issue. There's a big social issue. So we should be very, very careful in whatever we are doing. And that will be an important factor to consider. So I think we have tried to discuss about 3 very important issues related to different aspects of pediatric endocrinology, starting from type 2 diabetes to SGA and growth hormone therapy, and finally about gender discordance. We'll close now and we'll meet again with our